This is Chapter 23, Cardiovascular Dysfunction, Part 4. So we're still on heart failure, and right-sided heart failure means you're going to have too much pressure in the right side of the heart, so it's going to back up into the systemic vascular circulation. That's where you're going to see that peripheral edema or a distended liver. Left-sided heart failure, you've got too much pressure in the left side, and that is going to back up through the pulmonary veins into the lungs. So you're going to see respiratory symptoms. Now, having said that, realize that one side, when you really can't get blood coming into it, not adequately, and it's that what I'm calling the parking lot is filling up, it's going to make it hard for the other side to pump. So heart failure on one side can lead to heart failure on the other side. And the big issue with heart failure is we have inadequate cardiac output. We're just not getting blood through and out of the heart the way we need to. And here's a little schematic that shows the symptoms of left-sided versus right-sided heart failure. So to treat heart failure, we're going to use a lot of the same medications we use with adults. Digoxin, which is lanoxin, improves our contractility of the heart. It makes the heart beat stronger and slower. So it allows a little more time for the heart to fully fill, and then it makes a very strong beat. Then we'll also use our ACE inhibitors, captopril and enalapril being common ones, and we use the diuretics, Lasix, which is furosemide, diuryl aldactone. The nice thing with aldactone is it is potassium sparing, and you'll see they try and use a lower dose of the Lasix, furosemide, and then use some aldactone so that we don't have such an issue with losing potassium. These kids, depending on how bad the defect is, they are likely to be on a fluid restriction, and they have to keep track of how much they've had, or their parent does, and then as they grow into adulthood, they will need to, because the fluid restriction is usually for life. Sodium restriction, not usually common in kids, but you could see that, right? You have extra sodium, it makes you hold on to extra fluid. The heart can't handle the volume, so we don't want them holding on to extra fluid. That's why we're giving diuretics. It's important to monitor potassium, especially if we're giving furosemide, because if our potassium is low, the child can get digtoxicity more easily. A low potassium lowers the level of for toxicity on digoxin. So some of the therapeutic management is doing things to decrease their cardiac demands. We want to limit physical activity. We want them to play, but then have rest periods. When we go in to do our physical assessment and activities with them, we're going to group all those activities, do them all at once, and then let them rest. We are going to do anything we can to avoid a fever, treating infections early or treating fever more aggressively than we might in other kids, because if you remember, raising your temperature raises your metabolic demands. Their heart can hardly keep up with the metabolic demands as it is. It's not going to be able to keep up if you raise it. Positioning them semi-Fowlers, that's going to improve circulation, make breathing easier. And then sedating an irritable child. A kid who is screaming and fighting has increased their oxygen demand. Our goal is to decrease it, not increase it. So we never sedate a child for the nurse's benefit, but if it's for the child's, if it's in the child's best interest, then we might. And in a kid with a heart defect, we might need to do that if they're really screaming and unhappy. We can't let them use all that extra oxygen. Oxygen on these kids, it's going to depend on the physician's order, and it's going to depend on the defect, because sometimes Oxygen is of no value, and other times we're going to have it going. So it's just going to depend on the order. So giving digoxin. You always take an apical pulse for a full minute before giving it. And in adults, you hold it if their apical pulse is less than 60. For a child, we're going to hold it if their apical pulse is less than 70. For an infant, hopefully the physician gave us an exact number, but a child, if it's their apical is below 90 to 110, somewhere in there, they're already a little bit bradycardic and we don't want to give it. Digoxin is one of those drugs that the therapeutic window is very narrow. To be at a therapeutic level and to be at a toxic level is not very different, and so we're always watching for signs of toxicity. The earliest ones are nausea, vomiting, and anorexia, and unfortunately those can be anything, right? Who knows if it's digoxin or just the kid isn't feeling good that day. But bradycardia is also one, and so we're going to hold if we see that apical pulse a little bit low, and then dysrhythmias. Digoxin is a drug that we always check with another nurse, and we have to do blood levels to make sure that it's in that therapeutic range, which is 0.8 to 2. We also need to monitor potassium levels, because if their potassium is low, that toxic level is lower. So you will be toxic at a lower level. Instead of it being good to 0.2, it will be lower than that. If we give a child an ACE inhibitor, you have to do the blood pressure before you give the medication. And there's usually parameters with that as well. Here's a page from an old textbook that talks about the different medications, the different diuretics, and the nice thing with spirolactone aldactone is that it does not waste potassium. So you will see they often order some furosemide, Lasix, and some aldactone so that we get the diuretic effect we want without wasting as much potassium. Kids who are hypoxic it takes months, they will develop over time clubbing of the fingers and toes. And here's a really nice picture. You can see how this is almost kind of ping pong paddle shaped, right? It gets wider here. That is clubbing. And you can also see the kind of funny flat shape of the nail on that one. Hypercyanotic spells. These are often called tet spells because kids born with tetralogy of flow will do these. This is a sudden right to left shunting. So we don't really know why or what happens. Often there's nothing that really precedes it, but all of a sudden they will take that deoxygenated blood coming into the right side of the heart, shunt it across to the left and send it out to the body, and they will turn acutely cyanotic. They look blue, their sats drop, and it happens very suddenly. So the best and first reaction you should do is lift the child up and put them in a knee-chest position. And that kind of pinches off the blood vessels, making the pressure, that systemic pressure, a little bit higher, which hopefully then makes the left side of the heart pressure a little bit higher, so they stop that right to left shunt. We want to try and calm them down. Getting them crying is not going to help, so be very comforting and calm. Go ahead and give them some O2, just by face mask, blow it by, because we want to try and get as much oxygen in as we can, although if the blood is skipping the lungs, putting extra oxygen in the lungs has a pretty minimal effect. We might need to give morphine. We might need to give some fluid or volume expansion and then repeat the morphine, but usually that knee-chest position is the first thing, and if you do that and calm them down, they usually come back pretty quickly. So she's got the child upright and the knees up. I'd say these knees could even be kind of inside here a little more and up a little more. And then calm the baby down. Nursing alert, you've figured out I love the nursing alert boxes in the book. So This one says intracardiac right to left shunting allows air in the venous system to go directly to the brain, resulting in an air embolism. Right? So if you put a bubble of air into your IV, which is coming in the vein into the right side of the heart, but this kid has a defect and that crosses over to the left side of the heart and goes out into the arteries, it can go up to the brain, which is bad, obviously. So all IV lines on a child with a heart defect should have a filter. That's that 0.22 micron filter. It's small enough to catch air bubbles. You'll hear it called an air eliminating filter. You want to check this tubing for air. This is where little micro bubbles are not okay. Make sure connections are secure so that they're not going to let air get in there. And if you do see some air in there, you need to stop the line and get that air out, because a small bubble of air can be a significant problem. Usually it goes into the right side of the heart and into the lungs and kind of gets dissolved before any real problem can happen. But with a cardiac defect, that's not the case. So we can use that cardiac catheterization for some of our procedures. With a transposition of the great vessels, this is where we've got to make connection. So we're going to make a big ASD, and then other times we're just trying to stretch out and open up something that's narrowed and tight. So here's the balloon. This is coming up the pulmonary artery. Here's the aorta. Well, actually, I guess it's coming in through the superior vena cava and through the right side of the heart into the pulmonary valve, and then the balloon is blown up to stretch out that valve. I don't know if you can quite figure out that heart since it's only got a few pieces of it on there. Here's another one. So this one, again, they came up through the veins, through the inferior vena cava this time, just sort of pierced through, went through the atrial septum and over to the mitral valve here, got it in place, and then blow up the balloon to stretch that out. So we can sometimes treat things with that cardiac catheterization. So if we're going to do a cardiac catheter, we want to make sure we've got the child and the family prepared for what's going to happen. Use developmentally appropriate materials and think about the words you're using too. Make sure it's words that the child knows, and even some of our families are not very sophisticated in their medical vocabulary. We want to assess pulses beforehand because we're going to be watching for them afterwards. We want to know what their O2 saturation before the procedure is, and nothing by mouth before the procedure, right? Risk of aspiration, we don't want to do that. After the procedure, we're going to check those pulses. Sometimes you'll get a decreased pulse distal to where the procedure was done. We can get some swelling there. So we need to know what we started with so we can see where we're at after. We're going to monitor the temperature, the child's temperature for infection, and sometimes that can be a little reaction to any dye they used, but also the temperature of the extremity distal to where the catheter was put in, because again, we're watching for circulation. After the procedure, it's vital signs every 15 minutes, including blood pressure, monitoring that blood pressure, monitoring the dressing for any bleeding. If there is bleeding, you're supposed to put pressure a couple of centimeters, about an inch above where the puncture in the skin is, because when they go into the vessel, they're going at an angle. So where they poke through the skin is not where they poke into the vessel. So above, a couple centimeters above where the skin puncture is where you're going to put pressure if you need to for bleeding. Monitoring intake and output, because we want to make sure there's good cardiac output going through the kidneys, and then monitoring blood glucose as well.